Welcome to Observations, an open conversation about women's health. This is a space where physicians, patients, and other experts can sit down and have honest, evidence-based dialogue that cuts through the media bias and brings clarity back to maternal care and how we can care for both patients, mother and preborn child. With each episode, we will have real stories, real science, but also real questions about women's health today. From clinical insights to lived experiences, to aligned perspectives, and yes, also respectful disagreements. This is our goal, to bridge the gap between physician and patient, to empower informed decision-making, and bring back and elevate compassionate, fact-driven care. Now, a quick note before we dive in. Not every guest on the podcast is going to represent the views or positions of AppLog, but we believe that having open and honest conversations are going to make us better. So, grab your coffee, settle in, and let's get into today's observation.
Welcome to Observations. I'm Dr. Susan Bane, and I am excited to invite a colleague and a friend, Dr. Elizabeth Mumper, to our podcast today. So let me tell you a little bit about Dr. Mumper. So Dr. Elizabeth Mumper is a pediatrician and international leader in integrative and functional medicine, especially in the field of pediatrics, in which she is. She's been working for over 40 years, both in clinical settings, educational settings, and research. She is the former founder and CEO of the Ryman Center for Integrative Medicine, past Director of Pediatric Education at the Lynchburg Family Practice Residency, and a longtime clinician mentor for professionals worldwide. Dr. Mumper has delivered more than 450 invited lectures, published extensively on autism, immunity, and gastrointestinal health. She's authored Kids and COVID, Costly Mistakes That Must Never Happen Again. Her work has earned numerous honors, including the 2025 MAPS Trailblazer Award and the 2023 FLCCC Lifetime Achievement Award. And as a side note, she has been the pediatrician for my son Maxwell, who has autism, until he graduated from her practice. So Liz, Dr. Mumper, thank you for being with us today.
Susan, thank you so much. It's a real joy to be here. I appreciate the work you've done also.
Oh, absolutely. So, one of the reasons I really wanted you on our podcast is I know that you take a root cause approach to medicine. I think oftentimes allopathic trained doctors with an MD, drugs, medications, procedures, surgical type interventions seem to be what we're educated and learn the most on. And the approach that you take, that I've taken, is more a root cause approach with that integrative and functional medicine approach. And oftentimes, OBGYNs, we are asked questions where I want to phone a friend, and I want that friend to be a pediatrician. So for me, this conversation, I get the pleasure of phoning a friend and letting other people learn from you. So thank you for being here. All right.
And Susan, I would
Yeah.
clarify that I was trained very traditionally, very allopathically. I went to a very traditional medical school, the Medical College of Virginia, and then trained at the University of Virginia and was chief resident there. And my journey into root cause medicine really came probably 20 or so years after I was embedded in traditional medicine, where I worked both in a group practice and then in medical education or residency program, which I really love. So I have allopathic roots, but my wings are kind of the value of functional medicine and root cause medicine. Yeah.
So I have a similar background. I was at the University of Illinois for medical school and East Carolina University for residency. And for me, it was when I discovered my son at age 2.5, 3 was diagnosed with autism. And that led me, I naturally had that root cause approach, but it led me deeper into it. How did that journey happen for you in your practice of medicine?
Well, in about 1996, 1997, it just seemed to me that many more children had chronic illnesses and neurodevelopmental problems like autism and ADHD. And I very naively thought, well, somebody ought to check into that. And initially tried to do it within the residency, but ultimately decided after I had a patient with autism who really affected me that I would start a solo practice, which to be honest is difficult in pediatrics because it's always nice to not have to be on call every night for 15 or 20 years. But nonetheless, that's what I did. And I met a wonderful pediatrician called Mary Megson who practiced in Richmond. And she was actually the first one that alerted me to some of the medical problems of children with autism. She got me involved with the Autism Research Institute, and that I ultimately got to be medical director there for 5 years, and I learned so much um, trying to decide what research projects we were going to fund. We had a very collaborative approach where we asked parents what their insights were and what they thought we needed to study, and awarded our grants with that in mind. And all those things led me to find that there was a subset of children who seemed to not be born with the characteristics that would ultimately become labeled autism, but also had environmental reasons or reasons in their medical history that might have contributed to them changing their developmental trajectory over time. So that is the short story about how I got so into this, and then I became certified by the Institute for Functional Medicine, which I felt like was a pretty rigorous training program, and it wasn't pediatric specific. So, I had to learn all the adult endocrinology of pregnancy and, all about testosterone and all about cardiovascular disease and, adult pulmonary illness, all the things that I didn't really see much of, but were part of this ability to look at a big picture and network biology and systems thinking. And it was good, vigorous training for me, I think.
Yeah, I tell people that my boards, when I took the functional medicine boards, were harder than my written OB boards. It was hard. It was like your second year of med school because it was back to the basic physiology at the cellular level and understanding that if we can get the cell working well, then tissue works well, then organs work well, then the systems work well in the body. So when we
Exactly.
think, yeah, and so when we think about that, I think one of the biggest things is that common denominator of inflammation. And we know in pregnancy, we want inflammation to be well controlled. Um, let's talk a little bit. What's your thought on inflammation as a common pathway when we think about chronic disease?
I think it's probably one of the most common things. I think that if I had to pick a couple, I would say inflammation and mitochondrial dysfunction and chronic oxidative stress. So, inflammation, by its very nature, if it is not acute and becomes chronic, is going to ultimately cause oxidative stress and mitochondrial compromise. So, it certainly is at the root of many, many children who have autism as one of their underlying root causes. And in pregnancy, we have this advantage that the immune system is sort of dampened down because it does not want to have the mother reject the fetus, which, and otherwise might be looked at as a foreign body. And so inflammation in pregnancy can be particularly challenging, as you all well know, but we always try to get to the root cause. And I think one of the things that many people don't think of when they're thinking about what might be feeding inflammation is the foods they eat. So, one of my
Mhm.
wishes for pregnant women is that ideally 6 to 12 months before you conceive, really clean up your diet, eat as organic as possible, and please try to avoid ultra processed foods, which, have extra dyes and preservatives that are so challenging to our genes. Our genes had not seen all that stuff prior to 50 to 100 years ago. So eating real whole foods from the ground, from nature, is one way to really cut down inflammation. There have been some studies that have showed that if you have one fast food meal, that it elevates your your pro-inflammatory cytokines for 12 to 24 hours. So, there are people that for lifestyle reasons or personal choice, eat two fast foods meals a day. And so they're never really out of inflammation. So something simple like cutting out fast foods and ultra processed foods can really be great for making your pregnancy as inflammation normal as possible. So that'd be a good piece of advice, I think.
Yeah, I was excited to see the new dietary guidelines that really focus on whole foods and, really trying to get patients, which we're all the time talking about the lifestyle factors and environmental stressors, but how, real food matters and trying to stay away from the boxes, the ultra processed, but be more on the outside of the grocery store where we have our produce and our meats and less of those boxes. So fruits and vegetables, great. When you think about pregnancy, one of the things that also really matters we get a lot of questions about are women who are concerned about breastfeeding and feeling like having doubt that they can successfully breastfeed. Talk to us a little bit about how you talk to moms and encourage them to breastfeed.
Well, I do love for all my patients to breastfeed. There's so many lifelong, long-term good consequences for the child in terms of lessening their risk for both acute illness in the first year of life, especially respiratory issues and gastrointestinal issues, as well as lessening their risk for chronic disease later on, which includes things like diabetes and certain types of cancers. The rate of primary lactation failure, meaning a woman that really can't breastfeed, is less than a half of 1%. I think a lot of women that consider themselves to be failures at breastfeeding, it's because they didn't have the right support and they weren't using the correct physician. So if I had to pick one thing, I would say that um, a very common problem is not having the baby latch on correctly. If the baby doesn't latch on to a lot of the areola and put pressure on the actual milk ducts, it's not going to lead to milk squirting out. If they chew on the tip of the nipple, the mother will have exquisite pain and won't be able to continue because of pain. So I would say somewhere between 60 and 70% of breastfeeding problems can be alleviated by changing the position and making sure that that latch is really good. Most women are able to produce milk. Oddly enough, people who are anxious about not being able to produce milk activate their anxiety hormones, which sort of work against oxytocin and relaxin and those hormones that should be predominant during breastfeeding. So, it's hard to tell somebody just don't be anxious, but whatever strategies a mom can use, doing yoga, meditating, go into your happy place when you breastfeed, playing classical music, get some kind of strategy that really relaxes you. And then often the milk will flow. And then I would say the other thing is many women don't realize in the beginning how often you have to breastfeed. It's really about 12 or 13 times in 24 hours in the beginning to get your milk flow established. And so you can't just jump to an every 3 hour or every 4 hour schedule and have it work. I very much advocate learning your baby's cues for feeding and offering the breast whenever they want it in the first few weeks of life. And some of the cues are that they'll start rooting on their hands or they'll nuzzle their face into your chest where they're looking for the nipple. Obviously, they might cry or they might get more irritable, but you have to breastfeed a lot in order to train that wonderful dyad between the mother and the baby for being able to feed successfully. And I think, again, the vast majority of women can, but they have to have help a lot of the time. So don't be hesitant to reach out. I think pediatricians and obstetricians, should feel free to refer to lactation therapists who can really help the mom.
Yeah, I couldn't agree more. And I think so much of it is helping them understand that the so few women can't successfully breastfeed with the right supports. And so I appreciate you sharing that with our audience that it is such a low percentage, less than 1%. So I always jokingly say that God gave us our breasts for our babies, and they will typically work just fine, but you can't be expected to do something you've never done alone. And that's the beauty of lactation specialists. So, one of the things you mentioned, Dr. Mumper, was the value of gut health with breastfeeding. Talk a little bit about the importance of gut health, and particularly as an OBGYN audience, vaginal delivery versus C-section and what we know about the difference with gut health there.
Yeah, I do think gut health is really important for pregnant women as well as for their babies. And I like to see pregnant women either doing probiotics during pregnancy or doing a lot of prebiotics and fermented foods. Our gut bacteria do so many important things for us. They help with peristalsis, they help make vitamins. And I regard one of my biggest jobs as a pediatrician in the first year of life is to help that baby develop good gut flora. Now, the vaginally delivered baby has a leg up because that trip through the vagina inoculates the baby with a lot of good strains of gut bacteria. C-section babies are at a little bit of a disadvantage, but one thing that is so easy to try that I wish more doctors knew about is to use the vaginal secretions of the mother and essentially either use a gauze wipe of the vaginal secretions or even a Q-tip and take those secretions and smear them over the baby's face and body after the baby is born, essentially inoculating even a C-section baby with the vaginal flora. In the first year of life, I really try hard not to prescribe antibiotics because even one dose of amoxicillin for an ear infection has a significant effect on the baby's gut flora. And it can be built up later, but once you've established your gut flora in the first 1,000 days, it's much harder to change it for the better after that. So it's much better in the long run to avoid damaging it early on. If the mother is able to successfully breastfeed, that is fantastic for the baby's gut because the lactobacillus and the bifidobacteria that are normally present in the breast milk are exactly what that baby needs to establish good gut health. It is worth considering in babies who are not being breastfed to do infant probiotics. And I would caution people that a normal flora in the first year of life is different than probiotics one would use when they're 50 or 60 years old. So I do like infant specific probiotics because there are certain flora that actually have infantis in their name, meaning it's an infant version. And there are companies that specifically address that. And I like the multi strain ones that have somewhere between 10 and 15 strains of appropriate for the infant probiotics. I also like the idea when babies first start taking solid foods that you don't start with sweet foods. one of the reasons for that is that fermented foods are great for helping you establish good gut flora, and babies aren't likely to take pickle juice or sauerkraut, if all they've had before that is
Right.
bananas and applesauce. And, frankly, breast milk is very sweet also. So I like to start with more savory vegetables in the beginning so that we can eventually work in some tart fermented foods and have the baby accept it. Another good way to get some tart foods in is to make breast milk popsicles, where you essentially use expressed breast milk and then you put vegetables or even some pickle juice or some sauerkraut juice into a breast milk popsicle, and the baby licks that and is predisposed to like it because of the breast milk and then tolerates the other stuff that's in it also.
Well, I can honestly say I've never heard of that recipe for a popsicle. But that makes a whole lot of sense. I mean, there are often tricks that we disguise vegetables in so many other ways, but I hadn't heard that one. So thanks for sharing that. All
Yeah,
right,
it's a
let's move.
great thing.
Yeah, let's move to something that I don't know, a month or so ago was controversial when Secretary Kennedy talked about Tylenol in pregnancy. We've known for a long time, anytime in pregnancy when we prescribe any sort of medication or recommend something over the counter like a Tylenol or acetaminophen, um, that we want to always weigh the risk and benefits for both mom and baby and give the minimal dosage for the shortest period of time. And I really think that was just a caution that was trying to be emphasized, but it seemed to cause quite an uproar. So, talk to us a little bit about your thoughts related to this.
Yeah, I do think that the general principle is to treat the mother baby dyad as almost sacred. And you really have to question yourself when you go to prescribe anything. And since acetaminophen is available over the counter, mothers may not get the word that they shouldn't be using it regularly if they have significant pain. There are a couple of reasons. It notoriously is bad on the liver, and, most people who take doses occasionally are not going to have any liver issues with it. But there are subgroups of people that specifically have impairments in the pathway that it takes to detoxify acetaminophen that would have a lower threshold for having a problem with their liver if they take Tylenol, paracetamol, acetaminophen. Those are all the same thing. The other thing that I'm very worried about is that acetaminophen has been shown to deplete the body's stock of glutathione by as much as 30%. Now, I had never even thought about glutathione after my biochemistry class when I was doing traditional allopathic medicine until I started training in the functional medicine space. And I realized how important it is. It is our best intracellular antioxidant. It helps us with our detox pathways. It's essentially one of the gateways to detoxification. It's very important to regenerate our gastrointestinal cells. It's good mitochondrial support, and it helps balance our immune system, specifically making the Th1 cellular immunity and Th2 autoimmunity allergy arms kind of work in balance. So glutathione is very important. So acetaminophen depletes it by about 30%, but pregnant women also tend to have lower levels of glutathione than people who are not pregnant. So you get that double whammy in pregnancy. And I will tell you that in terms of risk of autism, which is kind of uh, my area of expertise or at least interest, many children, as many as 65 to 85% of children with autism have problems with their glutathione pathways. So I don't want to be taking away from a baby the ability to detoxify, to fight intracellular oxidative stress, to regenerate those very important intestinal cells, which turn over very quickly, to impair their mitochondrial function, which is at the base of all their metabolic functions, or to make their immune system any less well balanced. So I really try to protect glutathione. And that's why in my practice, we did not do the typical when we give vaccinations. Many practices say, oh, go ahead and give your baby some Tylenol before you even come into the office. That way, if they get a fever or fussiness, they'll already be covered. We never did that. And we tried
Mhm.
to use lukewarm baths and evaporation for fever so that we didn't have to use acetaminophen. And there is a warning about the use of ibuprofen under the age of 6 months because of kidney issues. But certainly over 6 months of age, I personally would rather give a baby some acetaminophen, some ibuprofen instead of acetaminophen because I'm trying to preserve their glutathione and their detoxification abilities. So that's my
Yeah.
strategy. And I think that that recommendation was great. I think that, with all due respect, President Trump at the end of that press conference, he kind of went on and on about taking away the acetaminophen and somewhat implying that if you did that, you'd cure the autism epidemic. That is not my take on it at all. I think that low
Right.
glutathione is an issue for a subset of kids with autism, but I do not think that everybody quit taking acetaminophen tomorrow, all the autism would go away. So I kind of wish they had stopped the press conference at a more moderate point rather than having it continue and potentially be misleading to some.
Yeah, I think when you think about all the risks of autism, develop the prenatal risks, you know, Tylenol exposure is just one of many. So let's talk
Yes.
a little bit about what should we as OBGYN doctors, when you're doing a prenatal history and thinking about that risk for autism, talk to us a little bit about that.
Yeah, so there are some identified risk factors. I'll just get hit a couple that I think are really important and well supported by the research. The first is that autism is more likely to happen in children who are born prematurely. And obstetricians are very well schooled, I think, in things you can do to try to keep the baby in the womb as long as possible. And, the extreme preemies have a higher risk of autism than babies that are only premature by 6 weeks or so. So anything you can do to avoid those premature deliveries would be great. It's also more common to have autism if you have certain chromosomal abnormalities, which we can't necessarily prevent, but it is possible that you can be aware of those ahead of time. And then we get into the whole issue that's very important to your audience about whether anybody would even consider a termination for a chromosomal defect or not. So I'll leave that for all the controversy that it evokes. But the third thing that I think is often very much overlooked is the value of vitamin D levels in a pregnant woman. And we know from a number of research studies that low vitamin D levels increase the risk of the child having autism. And I think one reason is that vitamin D acts a lot as a hormone and not just as a vitamin, and it also acts as a counter-regulatory cytokine for inflammation. So we know any source of inflammation in pregnancy is going to increase the risk of autism. So you don't want to have low vitamin D levels, making the mother and therefore the baby unable to counter-regulate their inflammation. And when I say low levels, I don't mean just be worried about a level that's, 18 or 22 nanograms per deciliter. I don't want the levels just to be barely above the prevent rickets zone, which is around 30 nanograms per deciliter. I want to see the mom with levels in the 50 to 80 range. And you can do that easily with supplements. So people ask, well, how much vitamin D would I take? Usually between 5 and 10,000 international units a day is going to be a good zone. But my answer is you take it till you get in the 50 to 80 range. The other thing is anything you can do to prevent infection. We know that certain illnesses, certain kinds of flus are particularly risky, and probably because they cause inflammation. And so you want to try to, avoid unnecessary exposures to illness and do all those things you can do to support your immune system if you are exposed to viruses. Things like taking extra vitamin C or perhaps taking zinc for respiratory infections or for COVID infection exposure. And then the last thing I would mention is that there are certain medications that have been associated with causing autism, and the most notorious are some of the anticonvulsants. So I am concerned in mothers that have seizure disorders that having to be on anticonvulsants during pregnancy is going to be a little bit of an increased risk factor for that mom.
Yeah. So when we think about, all that you just said there, I mean, that's a whole lot. And my first thing that I think some of our audience members are going to say is, what about the flu shot during pregnancy? If we're trying to reduce, you know, inflammation, what do the data suggest regarding that?
Yeah. So, I gave thousands of vaccines during my pediatric career, but the flu shot is not one of my favorite because through no fault of the people that make it, it's not very effective. Some years it's only about 13 to 20% effective because they have to try to use their crystal ball, which they don't have, to predict which of the flu strains are going to be the most important in the upcoming year. They're trying to make that decision 6 or 8 months before flu season, and they just can't always get it right. So I think that the bang for the buck, so to speak, is relatively low for flu. And if I had to choose between the mom getting a flu shot or doing, an organic diet and routinely taking vitamin C and vitamin D and zinc, I would vote for the supplements, but that puts me in the minority probably among physicians. One reason I also don't like giving vaccines in pregnancy is that any vaccine you give is going to be a mitochondrial stressor and potentially a pro inflammatory trigger. Just the process of giving a vaccine with adjuvants is going to turn on the immune system for a response, which is, what you want. But again, in pregnancy, you want to be careful not to overstimulate the immune system in a bad way. So there's something called maternal immune activation syndrome that those of us in the autism world know a lot about, but I'm not sure that obstetricians and gynecologists are taught about it. But there's great research out of UC Davis, and if you want to look it up, Judy Vander Worker and Paul Ashworth or Ashworth, I think, are the authors of a whole series of papers about how activating the immune system in pregnancy, and one could argue that would be through an infection like we talked about, or through vaccination, is associated with higher risk of having a child with autism. So some of your folks might want to do a literature search about maternal immune activation, and that might uh, give more information to help make informed decisions about flu shots in pregnancy. The other thing I like with vaccine decisions is taking to an account the individual person and the risk at the time. So, for example, I'm not sure that it makes sense to give routine flu shots to every pregnant woman who's, going to have most of the time that they would get the shot, which when I studied it used to be around 28 weeks. I'm not sure if that's still around the time. But if your 28 weeks is going to be in May or June or July, and you're going to deliver your baby before, flu season gets going, that might be one environmental factor you might want to take into account. And you might make a different decision for a mother delivering in August than you would for a woman who's going to deliver in February or early March.
I have one more general thought that I get often as an OBGYN um, about folic acid and what prenatal vitamin I should buy. Do you have thoughts related to that you can share with us?
Yeah, so I can remember very clearly when the papers came out in the early 1980s about the association with problems with folate metabolism and spina bifida, as well as other midline defects. So even things like cleft lip, cleft palate, is implicated there. And folate, as your audience knows, is very, very important for neurologic development and ongoing neurologic function. So, one of the things that was done, and this did help a lot of people, was to add folic acid to the food supply. And it was added to things like cereals, for example. But there's a very common um, single nucleotide polymorphism or SNP that many, many people have. So there must be some adaptive advantage to it, but it makes it difficult for people to methylate their folate, to add a methyl group to folate. And because of that, I actually prefer to give methylated folate instead of just traditional folic acid, which is in many prenatal vitamins. So you will see that as L-methylfolate a lot of times on the multivitamin. And that is the way that I would like to see it given to pregnant women rather than the synthetic folic acid that was put into the food supply.
If
And I do not know brands of folic acid very well for pregnancy. I don't know the prenatal vitamins, but I'm sure that you and your colleagues do and can look for that methylated version.
So, Dr. Mumper, what does the ethylfolated version versus our traditional folic acid that we see in so many of our prenatal vitamins do that is helpful during pregnancy?
Yeah, so people with certain genetic changes aren't able to attach methyl groups to their folate. There's a common SNP called MTHFR. There are also some methionine synthase SNPs that are involved in this process where the folate cycle, which in my head sits to the left of the methylation biochemistry, needs to have a methyl group attached as it goes into methylation biochemistry. And again, I hadn't thought about that for 20 years, probably after medical school, but that is so important for how we regulate our genes epigenetically. It's very important for how we make proteins. It's very important for how we make creatine. It leads down to glutathione production, and we've talked about how important that is. So, methylation biochemistry is one of those biochemical crossroads that, when it doesn't work well, it has a lot of bad downstream effects. And with regards to autism, one of the things that we really work hard on is epigenetics of perpetuating autism. So sometimes, if we can, for example, help these kids have better methylation biochemistry, they are better able to downregulate their pro-inflammatory genes, for example, and upregulate their more adaptive genetic responses to all the environmental challenges that we're giving kids now with, ultra processed foods and pollution and other stuff that's in the environment, heavy metals, the list goes on and on. So I do think that people should be aware that their methylation biochemistry is very important, and that if they are one of the people that has trouble with doing that, by just getting a non synthetic folic acid, but a methylated version of a folate supplement. That just essentially tweaks your biochemistry. It helps you overcome a blockade, essentially.
We hope that you enjoyed today's episode of Observations and that it broadened your perspective on women's health and how we can care for both patients, mother, and preborn child. If you like this episode, make sure to give us a 5-star review where you can find your podcasts. Make sure that you like this on YouTube and subscribe to our channel for more episodes coming up. And if you have any suggestions on any topics that we should cover or guests that we should have on, make sure that you email us at media@applog.org. Again, thank you for joining us for today's observation, and we'll see you in our next episode.